And for the endometrium, take a separate image. It is better always. Okay, this is endometrium. You will measure the highest point of height. It has to be perpendicular on to the long axis of the endometrium. Okay, and this thickness of this endometrium varies with the menstrual cycle that I discussed before. Okay, so these 4 images, you got it? So now says uterus right, and 6 says uterus left. That means I am going to see the cornwall area of the uterus. Why cornwall area is important? Cornwall area is important because cornwall ectopic pregnancy is not uncommon. When I'm going to get the number 5 says uterus, in this view you will get only the uterus, myometrium, no endometrium. So this is says uterus right. Make sure you write the text or annotation of on every image on the side, not on the image. And the same picture, it looks the same. Says uterus left. Okay, so you learned it. And the importance of this image is to see any abnormalities in the cornwall region. Okay, and next is says right adnexa and says left adnexa. Okay, 7 adnexa. How does it look like? And what is adnexa? Adnexa is the lateral portion in the pelvic cavity away from the uterus. Sometimes you will see the ovaries in the adnexa area too when it is in the normal position. Fallopian tube is in the adnexa. And you will see the 2 important vessels, hypogastric artery and the vein, and the muscles and other soft tissues. You will see the adnexa for the right adnexa. You will see the bony bone. Then you will see the two hypogastric vessels. Okay? Sometimes you need to click the color to identify the two blood vessels. And these hypogastric blood vessels are lateral to the ovary. Remember that. Lateral to the ovary, and ovary is medial to this hypogastric vessels. So 7 and 8 look same. It looks same as 7. So the SAS views on the uterus is over. Okay? So now I will show you the transverse view of the uterus. Number 9. Transverse uterus body. And number 10, transverse uterus body with measurement. Which measurement? Width. That means you will get the image. It is a transverse view. You will get the uterus middle. How are you going to know it is middle? You have to swipe. Then you will, your visual impression, okay, that is fundus, as middle, it is the body, and this is cervix. And the body has the endometrium. So this is endometrium. And this body you need to measure the widest part. You have to measure widest part through the endometrium. That is width. So in this way you will get the all dimensions. So this is anterior, posterior, and this is right, and this is left. Okay, so that is both 9 and 10 in the same image. 11. Transverse uterus fundus. So in this view you will get only the myometrium, only myo, no endo, and it comes a lot of bowel, as you know. Lot of bowel. Now 12, transverse uterus cervix. For the cervix, I'm drawing it here. You'll see the cervix and cervical canal is shining, and you'll see the is refracting shadow. Cervix is say 3 centimeter, 4 centimeter. So you have to swipe both from the isthmus to the external os, and take one picture from here. And make sure this cervix, you saw it in longitudinal view when the full uterus is there, and you have to check the cervical canal. Is there any fluid collection due to obstruction, due to polyp? Is there any presence of a polyp? Okay, so this is cervix, transverse cervix, and now 13, transverse vagina. This transverse vagina, how does it look like? Vagina is posterior to the cervix, so then you will see the vaginal lining inside, and the rest of them are vaginal musculomembranous tissue. You know that? So this is vagina. If you angle more, and you will see the anus is here. And if you angle up, you will see the cervix is there. Okay, so this is the transverse view of the vagina. Why we need to see the cervix? Because the cervical cancer is common. Cervix may have cyst, Nabatean cyst. Cervix even may have polyp. Cervix even may have fibroid. Cervix can have cervicitis, thickened, bulky. Okay, we'll discuss those in pathology. So now you need to know the anatomical relationship. So posterior to the cervix, this is the vagina. Posterior to the vagina, this is the anus. Okay, so you will know the relationship. And we also take another picture. I call it transverse false pelvis. What is transverse false pelvis? Because in the false pelvis there might be a mass, and the most commonly it is pedunculated fibroid from the fundus of the uterus. Pedunculated fibroid from the fundus of the uterus. So in the false pelvis you might see most of the time you will see bowel. It is too much bowel over there. Bowel is moving, and you might see a solid mass. Then you have to look for who is this. It could be a lymph node, it could be a lymphoma, it could be a fibroid. So that could be a fibroid, then it is connected with the uterus. Click the color, then you will see there is a feeding artery supplying the, this is bowel and this is fibroid. And it's a pedunculated fibroid. Okay, feeding artery is blinking. Okay, so in this way you can see. So this is all about the transverse views. So uterus is done. Now, and vagina is done too. Can we see the vagina in long view? Oh yes, we can. I always drew the vagina. You saw that. There will be bright hyperechoic line inside the vagina. You will see it. Okay, and if there's a tampon, you can see tampon gives the shadowing and echogenic line. If there's a collection of fluid, you will see it. So we will discuss in pathology. So now let me give you the protocol picture of the ovaries. Okay, so now it was 14, now it's 15. Says right ovary. Says right ovary without measurement. 16. Says right ovary with measurement. Okay, sonographically okay, we'll see the right ovary in sagittal view. Okay, and we will measure the length, measure the height. This is length and this is height. And if you see there's a follicle, so we need to measure the, if this is the ovary and there is a Graafian follicle, then we need to measure the Graafian follicle, its length and height in sagittal view. Okay, so this is Graafian follicle. Okay, and you write down, because you took the history of LMP, so it might be a Graafian follicle approaching to the ovulation. Now 17 says right ovary with color. Same picture, you get the ovaries, now you need to put the color. You put the color. When you put the color, then you will see the color outside, color inside is blinking. Then you will see the venous. Once you see this color, then record it and capture it. If you want to do the Doppler, you can do the Doppler from the artery, from the vein. Then appearance you will get based on the phase of the ovarian cycle. Okay, so this is sagittal approach. Now transverse. Transverse right ovary. transverse right ovary means, okay, let me take this off. Transverse right ovary, okay, without measurement, and 19 transverse right ovary with measurement. The right ovary usually comes with uterus. So this is anterior, this is posterior, this is right and this is left. You will see uterus, it depends on the position or location of the ovary with the uterus. Ovary could be any place in the pelvic cavity except anterior to the uterus is not a normal location. So anterior to the uterus is not a normal location. So now this is uterus in transverse view, and for the right ovary, you got it? Okay, so this is right ovary, and you measure the right ovary horizontally. This is for width, and you can also measure the Graafian follicle. So this is the mature follicle. You measure its width, so you will get, see, the measurement, the length, height, and now this is width. You can get the follicle size and the ovarian size too. Okay, so in transverse, 2 images. In SAS, with the color, we call it 3 images. Okay, so this is 5 images for the right ovary, and the same 5 images for left ovary. So 20 to 20, 21, 22, 23, 24. 24 for left ovary. Same style, same thing. So these 24 images are universally recognized to do the complete GYN protocol. Along with that, if somebody says GYN protocol with ovarian Doppler, so then you will have couple of extra images to recognize the color in the ovaries and do the Doppler to get the arterial Doppler, pulsatile arterial Doppler, and the venous Doppler. But arterial Doppler is more important. Make sure you write down the LMP, correct LMP. Sometimes patient does not understand the LMP and verify it and recognize that this is the history the patient is giving, that is the true LMP, and write the date on the corner of the image. So these are the protocol techniques. You complete the protocol. Okay, so now what happened? So protocol images, you are done. So then save the images and transfer to the server. Transfer to the server. And all the images are stored in that server. And whoever wants to retrieve the images, they can retrieve by the MR number or by the name. When it is in the server, then it can go easily to the radiologist, but you have to do little more. Write your preliminary reports. In the preliminary reports, what are you going to add? Normally, sizes, 3, length, width, height, shape, borders, echogenicity, texture, homo versus hetero, simple versus complex, vascularity, echogenicity could be multiple: isoechoic, anechoic, hypoechoic, hyperechoic. Vascularity: normal vascularity, hypovascularity, hypervascularity. And write any shadowing, abnormal shadowing, any enhancement, abnormal enhancement, any calcification, any necrosis, okay? And I will write down here okay, any pathology, write down pathology. What are the common pathology? It could be cyst, then it could be solid, and the cyst could be simple,